In this video, we'll discuss about unstable angina. This is the easiest form I have made unstable angina answer in so that we can understand it properly. So first of all, what patients fall into unstable angina? So the first one is the patient with recent onset of angina. That is for 6 weeks. Then patient with angina of any duration but occurs at rest. Now it has a special name to it. It is called the Prince-Mental angina. I'll discuss it later. Now the third category of patients that fall under it is patient with chronic stable angina with recent increase in intensity, frequency, and duration of pain. And the fourth category of the patients is the patient with angina pectoris developing or becoming worse within days or months or weeks after acute myocardial infarction. Okay, now the precipitating factors that lead to angina, the first one being the inappropriate tachycardia. In cases of fever, anemia, hypoxia. Also, if there is increase in the afterload, if there is increase in preload, also because of inotropic states, that is if the patient is taking sympathomimetic drugs. Now I'll draw a diagram to make you understand the pathophysiology of angina pectoris. It is quite easy to understand. First of all, just remember about the coronary artery disease. Okay, so in the coronary artery disease, we had some fibrolipid lesions, right? So just remember the type 5 of the coronary artery disease, where you had a fibrolipid lesion, type 5. Okay, now this lesion, it undergoes basically the plaque rupture. Now since it has gone plaque rupture, it has two pathways to follow. Okay, the one is this one, which is very common. This is the occlusive thrombus formation. Now this occlusive thrombus, as we all know, leads to acute myocardial infarction. Now another pathway is, it will have a labile thrombus. Now this is unstable angina. Now this will further form an embolization which will cause cerebral infarction. Okay, so this is the pathophysiology. Now coming on to the clinical features. In clinical features, as I told you before, that there is going to be a type 5 lesion. So what you will mention in the clinical features is, first of all, an atherosclerotic lesion. Now this lesion will have lipid content as well as fibrous content, and it will can be superimposed on thrombus. Then segmental spasm. Now in this, what we see is there is formation of segmental spasm in the vicinity of plaque. Now there will be reduction in coronary blood flow. Now what is NSTMI? This is basically unstable angina plus myocardial damage or necrosis. Okay, now coming on to the I'll also tell you about the Prinzmental angina over here. In this, what you see is basically the pain occurs during rest or at night. There is the autonomic disturbance because of the coronary artery spasms. Also there is ST segment elevation, and it occurs more in women who are less than 50 years of age. Now coming on to the diagnosis, first of all is history. Then there will be transient ST segment changes and T inversion changes, T wave inversion changes. Then there will be raised cardiac biomarkers. First one, CPKMB. Now this basically tells us about the reinfarction status. So it comes back to its normal level in 36 to 76 hours. Then is the troponin T and I. Now they increase in 9 to 12 hours of myocardial infarction. Then we have myoglobin. Now myoglobin is less specific, but it gives us an early diagnosis. Now there are certain new markers that are being used like myeloperoxidase, glutathione peroxidase. Now let's refer to the treatment. In treatment, what are the main objectives of a treatment? First of all is to increase the oxygen demand and supply ratio. Basically not to increase but to improve. Yeah, so improve. So the second one could be to decrease the afterload. Now how will the afterload be decreased is when there is relaxation of resistance vessels. Now these resistance vessels, there is relaxation, so there will be decrease in the total peripheral resistance, so there will be decrease in the blood pressure, and there will be decrease in the afterload. Now one of the precipitating factors was increased preload. Now we will decrease the preload. How will we decrease the preload is by relaxation of capacitance vessels. Now these will decrease the vascular resistance, this will decrease the heart rate, and due to which the preload will be decreased. Then another thing is by the blockade or attenuation of sympathetic influence, right? We were referring to some sympathomimetic drugs in precipitating factors, so we will decrease this influence, due to which there will be decrease in the contractility, then there will be decrease in the heart rate, and obviously there will be decreased oxygen demand. Also we will do coronary dilatation. Now let's talk about the drugs that are used in unstable angina, which is the most important part of this video. So coming on to the drugs, first of all we divide the treatment into a medical treatment and the invasive treatment. In invasive, I have already talked about coronary artery bypass surgeries and the percutaneous coronary angioplasty, PTCA. We will refer to them. You can see in another video that I have uploaded. Yes, and now coming on to we will discuss the medical treatment here basically. So first of all, just remember, in medical treatment there are two types of drugs that are given. One is the anti-ischemic drugs and one is the anti-thrombotic drugs. Okay, now in anti-ischemic, what we give is we give nitrates. First they are given sublingually, or that is buccal or IV. First we give a dose of 5 to 10 micrograms per minute infusion, which is raised to 150 micrograms per minute till relief. Okay, then we will give beta blockers. In beta blockers, the cardioselective beta blockers, so metoprolol 25 to 50 milligrams by mouth 6 hourly. After beta blockers, we can give calcium channel blockers. Also, we can give morphine sulfate in the dosage of 2.5 milligrams. Okay, now coming on to the antithrombotic drugs. In antithrombotic, we will divide them into antiplatelet drugs and the anticoagulants. Now in antiplatelet, we can give aspirin. Now first aspirin is given in the dosage of 325 milligrams non-enteric formulation. Then it is reduced to 75 milligrams per day. Now if there is cases of bleeding, then we do not give aspirin. Okay, then the second category of drugs is Pi2Y12 inhibitors. This is clopidogrel. Now first the loading doses of 300 to 600 milligrams loading dose, and then maintenance is 75 milligrams daily. Now there are other ones also like ticagrelor, prazoguanil, cangrelor. Now you can also give GP2B3A inhibitors, that is amciximab 0.25 milligram per kg bolus, then 0.125 micrograms per kg per minute for 1 day. Now coming on to the anticoagulants, this is very easy. First of all is the unfractionated heparin. There is this bolus that we give of 70 to 100 units per kg per IV. Then low molecular weight heparin, which is enoxaparin. This we give in the form of IV bolus 30 to 50 milligrams. Then bivalirudin. This is also given in the form of bolus. Then fondaparinux. This is given 2.5 milligrams subcutaneously. Now, this completes the unstable